All right, let's talk about Chapter 40, the accessory organs of digestion, liver, gallbladder, and pancreas disorders. So let's just take a peek at this picture here. So we see the liver, right lobe and left lobe. If you have a transplant, they usually take one lobe of the liver. If you're getting a live donor transplant, they'll take one lobe and replace that, which is a great thing. You can have live donor transplant. Also, I want you to notice the gallbladder, how that sits up next to the liver. And there's a duct that goes from the liver to the gallbladder. And that you've got the hepatic duct, and you've got the gallbladder duct, and then you've got a common bile duct. And notice where that goes. If you follow that down past the stomach, it empties right near the pancreas. In fact, it empties right almost into the pancreas. Now, this reminds me of something that's going on right now, and that's Miss Ginsburg on the Supreme Court, ancient lady, but tough as nails. So she's had cancer multiple times, and she just had a stent put into her common bile duct to open up for the cancer that she has, because she has a narrowing because of the tumor. But she had pancreatic cancer, and so notice how close that gallbladder common bile duct is to the pancreas. Also, that pancreas that hides behind the stomach is a major part of our digestive system with digestive enzymes. It's very lobular looking compared to the rest of the organs. You can see the spleen over on the far right there. That just breaks down blood cells. It has its own unique set of skills. Our stomach, we know is used in digestion, but right now, so the accessory organs, liver, gallbladder, and pancreas. So let's get started. Just wanted to give you a little, just a visual of what's going on here and how everything affects everything. That's a blanket statement, isn't it? All right, so let's do a quick liver review. So the liver is the largest internal organ in the body. It has specialized cells that carries out many critical functions. In fact, if we really got into it, it would be almost about 500. But the main ones we want to talk about is the ingestion of old red blood cells. Well, what happens when we get a breakdown of old red blood cells? Well, it's bilirubin. So bilirubin is a product of the normal breakdown of old red blood cells in the liver. Now, little babies get jaundice, don't they, from bilirubin, and because they're also having a breakdown of old red blood cells. They're getting new ones because they're getting new red blood cells carrying oxygen from their lungs now. They don't have to rely on their mom giving them oxygen. So sometimes they get jaundiced. Also, the initial breakdown product of unconjugated or indirect bilirubin. The liver then converts unconjugated bilirubin, I am going somewhere with this, by the way, into conjugated bilirubin and secretes it into the bile. The bile is produced in the liver. It passes through the cystic duct into the gallbladder for storage. When fat passes through the duodenum after you eat, the gallbladder and the liver respond by delivering bile into the small intestine, the jejunum, via the common bile duct. The bile emulsifies or breaks down the fat so it can be absorbed easily. It also neutralizes the acidic chyme as it leaves the stomach. Bile also plays a role in the absorption of fats, soluble vitamins, and the removal of toxins. As bile travels through the intestines with the chyme, in the large intestines, it is converted into urobilirubin and then into sterobilin. This final breakdown product of bilirubin is what gives stool its characteristic brown color. So if you've had a breakdown of the breakdown. So a breakdown of anything from the gallbladder down, you might have a brown stool. What color is it going to be? Well, you may have a clay or white colored stool because the obstruction of the bile prevented that breakdown product that gives the stool a brown color. So a clay colored stool means bile problems. So it took me a long time to get there, but got there. So I hope you got that visual. Also, it also has various metabolic needs. So carbohydrates, fats, proteins, and steroids, and detoxification. So liver detoxifies potentially harmful substances. It makes bile and secretes bile. It also assists in blood coagulation. That's why a lot of liver patients have blood coagulation problems. I'll get into some of those bleeding problems that they do have because they don't have coagulation. They can't clot. So they'll have blood coagulation problems. And also, again, let's just not forget the detoxification that the liver does, whether it be of drugs or in anything. All right. Sorry, I jumped ahead, but I don't want to forget to say some of these things, so I had to come back to this slide. So I need to keep my hands off of the mouse. All right. Hepatitis can be infectious or non-infectious. And regardless of the cause, symptoms are similar. So either asymptomatic or if asymptomatic, the disease follows a course of 3 phases. So this is on page 767, if you want to look at those phases. And that's the icteric, pre-icteric, and post-icteric phases. So since I'm here, might as well talk about it. I know it's on another slide, but since I got you there in the book, let's look at it. So the icteric phase is characterized by jaundice, light or clay-colored stools. Remember I talked about that. And dark urine. So bile can come out in the urine and make it very dark. GI symptoms from the pre-icteric phase often persist. The icteric phase lasts 2 to 4 weeks. Now I kind of jumped over the pre-icteric phase because you just have that general malaise, headache, right upper quadrant where your liver is pain, anorexia, nausea, vomiting, joint pain. So this lasts about 1 to 21 days, but they're just kind of general symptoms. You may not even realize that it's the hepatitis virus that you're getting. Remember, this is a virus. So the post-icteric phase, in the post-icteric phase, fatigue, malaise, and liver enlargement persist for several months. So in the pre-icteric and the post-icteric, you mostly have just general vague symptoms. In the icteric phase that lasts 2 to 4 weeks, that's where you get the clay-colored stools, the dark urine, the jaundice, and you might have some itching from that accumulation of bile salts under the skin. So you might have a lot of itching. So while you're on page 767, why don't we jump over to table 40.4? Because it has the different types of hepatitis there. And yes, okay, I might be repeating myself several times in this lecture, but it's pretty important, and I like it, so I want you to like it too. The liver is amazing. So hepatitis A. So you can notice that it's a virus, hepatitis A virus. Transmission is fecal-oral route, often contaminated water or food. So this is the hepatitis that when you go to a restaurant, maybe some restaurants get closed down because there have been episodes of hepatitis A come out of that restaurant. I think Chipotle had that problem one time. So prevention of that, so let me just say again, transmission route is oral via contaminated food or water. So that's pretty important to remember. So wash your hands after toileting, and that's real big right now with COVID anyway. So just get in the habit, right? A vaccine is recommended for traveling in certain countries. There's no direct treatment for A. So let's go to B. There is a vaccine for hepatitis B. In fact, you may have gotten it. As a healthcare worker, you should be getting the hepatitis B vaccine. The transmission route is contaminated blood, and as healthcare workers, we're exposed to blood all the time. It's introduced through the skin or mucous membranes via contaminated needles or other medical or dental equipment. So if you stick yourself with a needle by accident, don't think, well, nobody saw it, so I'm not going to tell anybody. Well, what if you end up with hepatitis? And then you've got, you can't, the facility can't support you with that because you didn't tell anybody. Also, the prevention for that is use disposable needles. Don't recap your needle. Screen blood donors. Use caution with body fluids. Gloves. Please wear gloves. Wash your hands before and after. A vaccine is given to people, including nurses, who are at risk for exposure. So, treatment for hepatitis B, nothing really available for that. We can prevent, we just can't treat. Interesting, isn't it? Okay, hepatitis C. So hepatitis C virus, you can get that contaminated blood introduced to the skin or mucous membranes, usually contaminated needles or other medical or dental equipment. Also, drug addicts who share needles can pass on the hepatitis C virus. Also notice here in the transmission route, unborn babies may be infected by their mothers. So if the mother has hepatitis C, the baby can get it through the placental perfusion of the blood. So prevention, avoid risky sexual practices with people who may have hepatitis C. Now the treatment for this, there's really no cure, but there is a treatment. So treatment is with interferon. It says ribavirin. There's also some newer treatments I'll talk about when we get to hepatitis C in the verbation of the book. Then the hepatitis C, it's really just a derivative of B. And then E. So remember that hepatitis C usually get jaundiced. And hepatitis B, there is a vaccine given to nurses, and that the nurses are at risk for exposure. All right, so we'll go back now to our original slide here. So most recover fully, but those with hepatitis B and C become carriers. So they can give it to other people. And because they're carriers, they also are at increased risk for liver cancer. So it can expand, that chronic inflammation. So chronic inflammation anywhere can lead to cancer. But hepatitis, inflammation of the liver, can lead to liver cancer. It's not unusual at all. All right, diagnosis is based on having viral specific antigens and antibodies. So the doctor can have some blood drawn that would have some specific viral antigens about the hepatitis A, B, C. Also, if your liver is inflamed, your liver enzymes might be elevated. So that would be another sign that you have hepatitis. Also, what if you just wake up yellow one day? So, right, so this is a little freaky looking. The viruses, what they look like. So the types of viruses. So hepatitis A, you can see how that looks. Fecal oral route. Hepatitis B virus, blood body fluids. Hepatitis C, body fluids. D, co-infection with hepatitis B. And E, fecal-oral route, which is just another breakdown of the other hepatitis. So, I know it looks a little bit different though, doesn't it? So these are the different hepatitis. So we want to try to prevent ourselves from getting these. And remember the different phases of hepatitis, the pre-icteric, icteric, and post-icteric phases. Remember that, let's see, what else do I have to say about this one? All right, I think we can go to the next slide. So if we go into your book, though, I just want to repeat again, I guess this is probably the third time. Hepatitis A is transmitted by water, food, or medical equipment. Water, food. Interesting. Hepatitis B, all body fluids. People can be carriers of hepatitis B, not have really the symptoms themselves, but they can transfer it to somebody. Let's turn the page. And there again, we have that table 40.1 on page 766. And then we can go to page 767. Hepatitis C, transmitted by contact with contaminated blood or medical equipment. Now, I used to treat hepatitis C patients with interferon. It's a pretty very labor-intensive treatment. It used to be 3 times a week. They had to inject themselves with interferon. They had to be pre-medicated with Benadryl and Tylenol because they got a fever and a reaction. So, but now it's come a lot better. They have better treatments. All right. So patients are at risk, our nursing interventions, reduced activity tolerance. So tired. And plus, rest is necessary so the liver can heal and regenerate new cells. So that's a really good reason to rest, to give the liver a chance to heal and regenerate. It doesn't have to, you probably don't feel like eating much, so it doesn't have to break down the food and maybe not make so much bile, so we want to give it a lot of rest. Inadequate nutrition. So patients with hepatitis have inadequate nutrition, and nutrition is essential to decrease the demands on the liver. So they don't eat too well. They're a little nauseous and tired. Fluid volume deficit or excess. So if they're at a deficit, they have good hydration, and they can have good hydration. It's very necessary, maybe IV fluids if they can't eat or drink. Always good to know their I and O, what goes in must come out. Then we know they're not retaining fluids and becoming fluid volume overload or excess. So remember, excess fluid volume. Now this is a concept. Excess fluid volume, your symptoms would include edema, increasing abdominal girth. Your abdomen might get bigger because fluid is going into the abdomen. I'll be talking about this a little bit more later on, but what happens is a lot of the albumin from your blood volume in the veins and arteries, the albumin goes into the abdomen, and then it builds up fluid because albumin pulls fluid in there. A lot of patients have to have that fluid pulled out with a paracentesis so that it helps them breathe better if they get that fluid out. And then as a nurse, we want to measure that abdominal girth to see if it's getting bigger or smaller. And remember, you find one place. I use the belly button as the site where you would measure. And you can document the increasing abdominal girth or decreasing if there was a paracentesis, and then you can monitor if it's getting bigger or smaller. Also a rising blood pressure because you've got increased volume in your blood vessels, so the blood pressure is going to go up. Because as the heart pumps, it's pumping more, so the blood pressure goes up. So potential for disrupted skin integrity. So because the patients itch from that bile salts under their skin, they might have breakdown of their skin from itching. And any open area is going to be an opening for an infection, right? So we don't want that. And also, it drives you crazy to watch a patient itching themselves. So a lot of lotion, put that on their skin, lubricating it, trimming their fingernails so they're not sharp to break the skin. Sometimes mittens are applied so that their nails don't scratch, because even if your nails are short, if you do it deep enough, it can make a mark. And then again, altered body image. So because the patient might be jaundiced, I'll never forget the first patient I saw that was jaundiced. And I could have sworn that they would glow in the dark. They were that yellow like your yellow marker. Jaundiced. Not only their skin, but the sclera of their eyes were bright yellow. I don't know how, when she looked in the mirror, that she didn't realize that she looked different than what she should look, but the world looks yellow through a jaundiced eye, so that's what they say. Anyway, it usually resolves in about 2 to 4 weeks. All right, so let's just go back to your book for a second before we go into this other alcohol-induced liver disease. So we talked about, we're on 767, we talked about all the hepatitises, how we get them, right? So I want you to remember all that. Complications, B and C can become carriers and pass it on to other people under complications, and that they're at increased risk for liver cancer. People who have hepatitis cannot donate blood. So that's going to be in your history. Have you ever had hepatitis? Have you ever been exposed to anyone with hepatitis? And then, can you donate blood? Also, complications of hepatitis would be chronic hepatitis, fulminant hepatitis. That just means it's just really, really bad. Cirrhosis of the liver, liver cancer. Liver damage continues and may lead to cirrhosis, which I'm going to talk about. If necrosis or damaged cells occur without regeneration, fulminant hepatitis results. Severe liver failure may follow and is often fatal unless a liver transplant is done. Now, liver patients die from other things besides liver failure or fulminant hepatitis because there's so many complications that are involved with liver failure. So I want to talk about fatty liver here on this slide. Fatty liver is reversible if alcohol intake ceases, but there's also something called NAFLD, which is non-alcoholic fatty liver disease. In that case, it's not from drinking alcohol. It's from eating a poor diet. So the treatment for that is limiting the fat. What happens to the liver here is it does get cirrhotic, which means it kind of shrinks and it's not its normal size. So they can have problems on down the line because their liver does not function properly because it's tight. And then there's alcoholic hepatitis, which is inflammation of the liver and common with heavy consumption. Now, when you take your history and you ask your patients, do you drink? They'll say, oh, socially. It's probably not true. They probably drink more than they admit. So you may think, oh gee, wow, they've got alcoholic hepatitis and they don't drink that much. Well, that's because they're not telling you the whole truth. Because to tell you the truth, these liver patients I used to take care of, they would drink, I would swear it would be all day long. I don't know how you'd have time to do anything else but drink. You'd drink a bottle of beer an hour. I mean, they'd go through 2 6-packs in a day. And it is commonly beer. And then the alcoholic cirrhosis, which is actually where the liver begins to shrink and be non-functioning. Okay, let's move on. So let's get to cirrhosis. So now we're getting to page, well, let me just stop for a second. I know as we go through the book, I see things that I want to point out to you, and the slides in the book, I try to put them together, but sometimes I find things I want to point out. So I found something. So go to the patient teaching page on page 769. This is hepatitis, I know. Take precautions to avoid exposing others to the virus. People who have had close contact with you should see a physician immediately. A vaccine or immunoglobulin may be available to protect them from infection. Do not share personal items or utensils with others. Wash your hands thoroughly after toileting. If you have hepatitis B, use condoms for sexual intercourse. Your partner should be vaccinated against the hepatitis B virus. And do not expose others to your blood. Okay, so here we are with cirrhosis. So cirrhosis is a chronic progressive disease of the liver that's characterized by degeneration and destruction of liver cells. This highest incidence of cirrhosis is between the ages of 40 to 60. And if we think back to the Erickson stages of life, this 40 to 60 years of age is when we're like, our kids are teenagers, lots of stress, we've got stress at work, and we might drink to calm ourselves or get de-stressed. So that is the highest incidence, and that's probably the reason. There's 4 major types of cirrhosis. There's alcoholic cirrhosis caused by exposure to alcohol. There's post-necrotic cirrhosis, complications of hepatitis, where there's a massive amount of liver cell necrosis. Biliary cirrhosis develops as a result of obstruction to bioflow. So think about how the liver and the gallbladder are connected by that biliary tree, I call it, because there's actually like 3 branches. There's one from the liver, one from the hepatic duct, one from the gallbladder, the cystic duct, and then the common bile duct where they meet. So it's kind of 3 blood flows. All right, so also cardiac cirrhosis, and that follows severe right-sided heart failure. So if you think about that right-sided heart failure, the backup from the right side of the heart will affect the liver. The liver's right there on the right side. It can also affect kidneys, but right now we're talking about liver. So, but just know right heart failure can affect liver and kidneys. So let's go on to that. But let's look at signs and symptoms in your book on page 770. So resistance to blood flow from the intestines to the liver causes circulation to become congested in the intestines, stomach, and esophagus. So these are signs and symptoms on page 770. So because the liver is congested or not functioning well, there's a backup. There's a congestion in the intestines, stomach, and esophagus. The elevated pressure in veins in the GI tract causes them to dilate and bulge. Now this is important as we learn about what happens with liver disease and some of our nursing interventions. So let's read on. I'm at the bottom of page 770. So dilated veins in the esophagus. These are esophageal varices. They're similar to hemorrhoids. They look like hemorrhoids. And it says that at the beginning, top of page 771. They're prominent veins that can be visible in the abdomen. What happens sometimes is these veins rupture, and that's when they get massive upper GI bleeds. And then the doctor would have to go in and band those dilated blood vessels and might wrap a band like a rubber band, you can picture, wrapped around them to stop them from bleeding. They also can burn them so they stop bleeding also. Later signs and symptoms of cirrhosis reflect liver's inability to perform its normal functions, and I'm still on page 771. Jaundice develops because of elevated serum bilirubin levels. So two factors contribute to jaundice in the patient with cirrhosis. First, diseased liver cells may be unable to conjugate and excrete bilirubin. So then you get jaundice, you get the itching. Second, changes in the liver prevent the normal flow of bile out of the liver. So another effect of impaired bilirubin excretion, as previously mentioned, is the deposition of bile salts under the skin, leading to intense pruritus. The diseased liver is unable to metabolize estrogen, testosterone, aldosterone, and adrenocortical hormones. Therefore, they exhibit signs and symptoms of hormone excesses. Testicular atrophy, impotence, gynecomastia, remember that's breast enlargement in men, amenorrhea, lack of menses, palmar erythema. So that's interesting. Palmar means the palm of your hand. Erythema is redness. So take a peek at some of your patients. Sorry, my dog just walked in. Got to get him out so I can talk. All right. Palmar, as I was saying, I lost my place. Palmar redness. So look at the liver patients that you have and notice, are their palms really red? Because that's really diagnostic. Spider angiomas. So check at their abdomen. Do they have these little spider-like blood vessels that are distributed on their abdomen? They're attributed to hormone excess. Cirrhosis impairs the liver's ability to manufacture albumin. Albumin is protein, right? Albumin plays a critical role in creating colloid osmotic pressure that retains water in the vascular compartment. So we need a normal albumin, which is protein, in our blood. A lot of the elderly have a low albumin because of their diet, but liver patients have a low albumin in their vascular system, but they might have albumin in their abdomen, their enlarged acidic ascites abdomen, where they retain water. So ascites is the accumulation of fluid in the peritoneal cavity. So I'm on page 771. Just want you to keep up with me. So I want you to look at this guy, figure 40.1, and this tells you all the things that liver disease can do. It can affect you neurologically with the hepatic encephalopathy. And that is something that I'm going to talk about shortly here. Also, peripheral neuropathy, so it affects the neurons. GI-wise, anorexia, dyspepsia, change in bowel habits, You can read through all that. The esophageal and gastric varices, which causes the bleeding. Hematemesis, the vomiting of blood. Reproductive disorders. Integumentary, the jaundice, the spider angiomas, the palmar erythema. Purpura, the little red dots under the skin. Petechiae, same little dots. Hematologic anemia, thrombocytopenia because of the clotting factor in the liver, leukopenia, coagulation disorders, again clotting problems, clotting in the liver is very important. Splenomegaly, well, we didn't mention a lot about the spleen before, but we know that it's in that area, right? So, of course, it can have some enlargement because that whole area in your assistive organs of digestion can also become enlarged. It also helps break down red blood cells, so if the liver's having problems, the spleen might have to kick in and break down blood cells, so it can become enlarged as well. I know there's a lot that goes on in the liver, and so do you have to remember everything? Well, it's a good idea to have that general concept of all these things that can go wrong. So we know cirrhosis is a bad thing. We know that they're going to be jaundiced. We know they can have ascites. I'm throwing out some really good words here that we need to know. All right. So some complications. This is important. Risk for many complications related to portal. Now, portal always refers to the liver. Hypertension. So blood pressure, high blood pressure in the liver really is what they're talking about. And that's what causes those blood vessels to dilate and get big and then maybe rupture and have them bleed. And I'm telling you, I've taken care of several patients with esophageal varices, and they can bleed and then they get fixed up, right? You know, the doctor takes care of that bleeding, but it's going to happen again and again. So liver disease is pretty, once your liver starts failing, you're going to have all kinds of things fail as well. So that leads us to complications on page 771. Portal hypertension, as I said, liver insufficiency, esophageal varices, ascites, hepatic encephalopathy. That's ammonia. The buildup of ammonia in the blood can cause us to get really foggy. And liver patients a lot of times have a buildup of ammonia. They'll be on lactulose, which helps them get rid of this ammonia. So they'll have ebb and flow of their mental status. They might even almost be comatose because of this buildup of ammonia. Hepatorenal syndrome. So that's interesting. So there's a very thin line when patients have to get a liver transplant. So their liver's failing, right? And they're getting to the point where they need to be on a liver transplant line or list. So because the kidneys are right there, their kidneys may start to fail also. And if that happens, that's a hepatorenal syndrome, and that can put them over the line of being eligible to get a liver. Because once they have kidney failure, or their kidneys are affected, their BUN and creatinine are rising, then they need some kidneys too. So now they need liver and kidneys. Now, some patients are lucky enough to be able to get both of those. Some patients are lucky enough to get a liver without going into the hepatorenal syndrome. Also, bacterial peritonitis. Patients can get that. That's, remember, an inflammation in the peritoneum. That could be from a from getting a paracentesis with the needle put into their abdomen. And some patients have to have it done every week. They need to get 1 or 2 liters of fluid taken out of their abdomen so that they can breathe, so that they can walk, because that enlarged abdomen puts weight on their legs, so their legs get swollen. They can't really sit very comfortably, and they can't walk around comfortably. It's a very uncomfortable situation. So I'm on page 772 now, talking again about portal hypertension. So the portal vein delivers blood from the intestines to the liver. Changes in the liver with cirrhosis obstruct the flow of incoming blood, causing blood to back up in the portal system. So that's a backup, a buildup of blood and volume, causing hypertension in the liver. So in that case, they're really at risk for bleeding because of this portal hypertension causing the esophageal varices. You can see that's the next one under portal hypertension on page 772. So because of this very sensitive time in their liver failure, they need to avoid straining to go to the bathroom. Now, a lot of times constipation isn't a problem for them because lactulose, which is a treatment for the ammonia buildup in the brain of a liver patient, usually causes diarrhea, so you have the opposite problem. But if they do get constipated, they need to avoid straining. That's important because if they're straining, that raises the blood pressure in their portal system, which could cause them to bleed. It also causes increased abdominal pressure. So also heavy lifting. This is all under your esophageal varices on page 772. And then it talks about ascites, the accumulation of fluid in the peritoneal cavity. And it's usually albumin-rich fluid that's in the abdomen. So let's talk about that hepatic encephalopathy I keep referring to, because it's important that you understand that. So the failing liver is unable to detoxify ammonia, which is a breakdown product of protein metabolism. Excessive ammonia in the blood causes neurologic symptoms. Important for you to remember that, neurologic symptoms, because that encephalopathy, just telling you that, it means your brain is all foggy. And that's neurologic, isn't it? Your brain is part of your neurologic system. So cognitive disturbances, declining level of consciousness, they're difficult to arouse, they're difficult to awaken sometimes. And sometimes I had one patient I remember, young guy too. This can happen young. I would call to him and he was very difficult to arouse, and when he did arouse, he was confused. So they don't just suddenly wake up and they're perky, right? They are confused. He wouldn't know who I was. He didn't know who his wife was. He would do kind of strange thing, try to get out of bed even though he couldn't, but he insisted that he could. So they get really confused. All right, so when they have this hepatic ascites, esophageal varices, portal hypertension, those things on page 772, one of the nursing interventions that we would do in this time as they get ascites buildup is measure their abdominal girth. So I know I mentioned this before, but it must be important. So get a paper tape, keep it in the patient's room, measure, always try to measure at the same place, which is around the belly button. You can mark it with a marker so every nurse knows where to put the top or the bottom of your measure. Now be sure you document that. Okay, I'm marking this line at the top of the tape measure, and I'm going to measure the abdominal girth there. And then also, what's the other thing that we could go by with volume? Is the patient retaining volume or increasing their volume? Well, weight. We want to weigh our patients. So that would be one of the doctor's orders, I'm sure. Okay, we talked about the Hepatorenal Syndrome. The vasodilation associated with portal hypertension constricts the renal blood vessels, so that's why they get the kidney problems or renal problems. The Bacterial Peritonitis, common fever, jaundice, abdominal pain. So some blood tests. What are some blood tests that are done? Results of blood tests that are consistent with cirrhosis include serum and urine bilirubin. So a bilirubin going up means your liver is getting worse. But if your bilirubin is going down, your liver might be improving. So remember that. It's important to remember. Also, your other would be ALT, AST, liver enzymes. Also cholesterol, prolonged pro time, CBC. Those are all some other blood tests that could be done. Now, how do we diagnose liver disease? Liver biopsy. So a biopsy is like a little punch biopsy, right? So remember, before the procedure, take baseline vital signs and blood coagulation studies. The patient should be NPO. They need to sign a consent. Patient should void before starting. They will be given probably a sedative to relax them, but it needs to not be so much that they can't follow commands, because they're going to have to put their arm above their head to spread apart the ribs so the doctor can go in between the ribs and do a biopsy of the liver. Now, usually this is done in radiology by an interventional radiologist, so he can see where the needle is going into the liver, because we don't want him to puncture something wrong. All right, the patient takes a breath, the doctor goes in, takes a biopsy. Hopefully he gets enough the first time, because they are at risk for bleeding. Now, how do we position them after a biopsy? Well, because they are at risk for bleeding, we're going to put them on their right side for 1 to 2 hours on top of the liver biopsy dressing. And the whole body weight of the body is put on that wound or that site. But you need to check it every once in a while to be sure it's not bleeding too much. So monitor the vital signs, breath sounds for signs of hemorrhage. And here's that concept of hemorrhage or hypovolemia: increased pulse, decreased blood pressure. A pneumothorax would be shortness of breath or dyspnea, chest pain, restlessness. Remember, restlessness can be a sign of many things, but lack of oxygen is one of them. Absent breath sounds on that side. Tell the patient to avoid strenuous activities and heavy lifting for 1 to 2 weeks, and report any fever in case they get an infection at that site of the biopsy. Medical treatment, important to know. The goals of medical treatment for cirrhosis are to limit deterioration of liver function. So they've got a bad liver, but we don't want it to get worse. So we try everything to prevent it from getting worse. We're going to promote rest so the liver can rest and regenerate. That is the cool thing about the liver. It can regenerate. So if you took part of a liver of a live donor, they grow another liver, as does the person who lost part of their liver or got a lobe of someone else's liver. They're going to grow a full liver. That's pretty amazing. All right, so promote rest. Bed rest is ordered. Malnutrition is common. By the way, I'm on page 772 under medical treatment. They need a diet high in calories, carbohydrates, and vitamins. Protein might be restricted to prevent that encephalopathy caused by accumulation of ammonia. We got to get a dietitian on board. Anorexia is frequently a problem with cirrhosis, and now I'm on page 773 at the top. So small, semi-solid, or liquid meals may be better received. Enteral feedings may be needed to provide adequate nutrition. IV fluids may be needed to correct fluid and electrolyte imbalances. Anemia may require blood transfusions. Water and sodium are likely to be restricted because they might be getting fluid volume overload. So we want to hold their water and sodium, so be sure when you're keeping your I&O. In that case, we might want to have a lower intake than output because we're trying to get rid of some of those fluids. So they would be on cathartics, like that lactulose, and antibiotics may be used for hepatic encephalopathy. Also, beta blockers, such as propranolol or Inderal, may be prescribed to reduce the portal pressure. All right, so now it takes us down to ascites. It's talking about ascites again. The medical treatment of ascites aims to promote reabsorption and elimination of the fluid by means of sodium restriction. So their diet would be sodium restriction. And remember, again, we're also going to measure abdominal girth and weight, do their weight. They might be on diuretics to help get rid of extra fluid. Spironolactone and furosemide or Lasix or both. Combination of diuretics. Bumex is another diuretic. It's a very potent diuretic, but they might need that. Depends on what level of liver failure they're at. Some salt poor albumin may be given IV to help maintain blood volume and increase urinary output. Albumin raises the serum colloid pressure. What that means is if they're losing albumin into their abdomen, if you give them increased albumin in their blood system, their vascular system, it might draw back the albumin from the abdomen as well as the fluid. And then hopefully they can, either through diuretics or hopefully their kidneys are still working okay, then they can just pee out that excess fluid. All right, if ascites doesn't respond to conservative treatment like the diuretics and the albumin and a paracentesis, alternatives to that is a placement of a peritoneal venous shunt or transjugular intrahepatic portosystemic shunt. Also short tips, it's called. We'll discuss that a little bit later. It's over under shunts, and there's several different types of shunts that I'll talk to you about. Tips is a pretty common one. So paracentesis, and remember, if you're going to be the nurse helping with that, you've got to have several bottles, liter bottles ready for the doctor, maybe 2-3 liters he takes out. I think the ratio is 4 liters, 2 to 4 liters. If they take that out of the abdomen, they've got to replace it with some IV albumin because it takes out so much albumin in the abdomen. And electrolytes as well. All right, so always obtain baseline vital signs, weight, and abdominal girth. That keeps coming up, doesn't it? Right, now I'm going to get down to, all right, here it says, the physician may request monitoring vital signs during the process of the paracentesis. Usually 2 to 3 liters of fluid are removed slowly. Rapid removal can cause a circulatory collapse because of the fluid shifts. Sterile dressings applied. Monitor vital signs every 15 minutes until the patient's stable. Check the dressing for bleeding. You might be sure you measure that fluid as output that the doctor has drained off. And he might want a specimen sent to the lab. So you're going to document the procedure, how the patient tolerated it, the amount and color of the fluid, and it's usually kind of yellowish. Monitor for blood in the urine, and then the IV albumin that may be ordered, so that would be intake. So that takes us to shunts on page 773. Shunts provide a mechanism to collect acidic fluid and return it to the circulation. So the doctor doesn't pull it out, which creates a whole big shift in the fluid volume in the patient's body, which can lead to some problems. So they'll put a shunt in. Advantages to shunting acidic fluid rather than removing it are, again, that's shunts on page 773. Shunting acidic fluid rather than removing it are protein-rich serum is retained and returned to the vascular compartment. Number 2, urine output increases, which eliminates excess sodium in water. So here, this is important. Several types of shunts exist. Now we talked about the tips, the transhepatic portal shunt is the preferred treatment. A catheter is threaded through the jugular vein, in the very inferior vena cava to the hepatic vein. The hepatic vein is punctured and connected to the portal vein with a stent. So one problem with tips is that toxins in the blood bypass the liver and may cause encephalopathy. So these patients, needless to say, are high maintenance patients. They need a lot of care. So also not all patients are candidates for this procedure. So 2 other types of shunts are the portocaval and distal splenorenal shunt. They are surgical procedures. You can read about those. They're just recirculating the hepatic volume. But they're always at risk for other things. So I do believe there's a shunt I wanted to call your attention to. It's not mentioned in the book per se, but if you turn the page, I'm going to have to turn the page and we'll go back. So turn the page 774, where it talks about, this is figure 40.2, portosystemic shunts. We have a portocaval shunt and a distal splenorenal shunt. So one of the names of the shunt, I don't think it's listed here. We talked about tips, but another name you might see is something called a Levine portal shunt. And that prevents the loss of protein, which is a problem with these patients. So a Levine or a TIPS are portal shunts that route the fluid from the liver because liver can't handle it. Okay, go back to page 773. Bleeding esophageal varices. Several techniques can be used to control bleeding. Drug therapy, like the beta blockers, might reduce the pressure in the liver there. Sclerotherapy, which is just the injection of maybe saline. Endoscopic ligation, the rubber banding type, ties them off. There's also a gastric balloon that can be used to stop hemorrhage. Back in the old days, my days, it was like an NG tube that was inserted into the stomach, and a balloon was inflated against those esophageal varices to stop the bleeding. So it's pressure from the balloon that stops the bleeding. But the problem with that is that the balloon has to be inflated tight to stop bleeding, right? And we know esophagus is right next to the trachea. So think about that. If you're inflating a balloon in the esophagus and it is big enough to go against the trachea, what might be the problem? Breathing might be a problem. So you've really got to watch these patients' breathing, because that balloon could be inflated enough to affect the trachea. And if you've got ascites going on too, their lungs aren't breathing well, there are all kinds of problems. All right, so the bleeding esophageal varices is a problem. In addition to blood transfusions, vitamin K and proton pump inhibitors, that's big for these patients. We don't want acid in the stomach because they already have these distended blood vessels in the esophagus. So like protonics might be given. Lactulose is administered to prevent breakdown of blood in the intestines that would release ammonia, and that makes them poop a lot. So I'm on page 774 now, talking about the sclerotherapy, where they inject into the varices to harden and close them. It doesn't always work because of this portal hypertension. And then we've got the hepatic encephalopathy on page 774, which is just a buildup of ammonia, and it gives neurologic malfunction, and the patient might get confused and lethargic. Also, the Hepatorenal Syndrome, which occurs, it may be treated with a vasoconstrictor called octreotide. That's an interesting one. Have you heard of that one before? Have I mentioned that before? No, I don't think so. So it can be treated with a vasoconstrictor octreotide. Now, so that would be a patient in an ICU, and that's an IV drip. And a lot of times the physician will order octreotide drip so that the patient doesn't bleed until they can get to the hospital to stop the bleeding. So, octreotide. Albumin or TIPS patterns should not receive nephrotoxic drugs. Patterns, I said patterns. I meant patients, sorry. So you guys need to take a rest probably from me at this point, because since I'm starting to slur my words. So you can take a break. It's been an hour. I know it's a lot of information. So if you have to, that's fine. But please come back, because I have more. I'm going to keep trucking along. I'm going to take a drink of water and keep talking. It's really interesting. And as you can tell, I think it's amazing. All right. So let's talk about the spontaneous bacterial peritonitis. So it has to be treated with antibiotics. So imagine these patients, albumin, they're getting octreotide, they're getting beta blockers, they're getting lactulose, they're getting a lot of medication, aren't they? So now we have to have antibiotics on top of that? Well, maybe, to treat bacterial peritonitis. Drug therapy. So a variety of drugs may be used to treat the effects of cirrhosis. These drugs and nursing implications are summarized in table 37.2. So you might have to go back to chapter 37, and I'm going to go there right now, because why shouldn't I? If you got to go there, so should I. So let me find them here. Bear with me. So on page 713, it talks about lactulose under other agents. and that's the increases fecal water content, so you can see why they get diarrhea. To stimulate bowel evacuation, treats hepatic encephalopathy, to promote passage of ammonia. That's lactulose. And when you're in the long-term care facility, sometimes the lactulose comes in a bottle or a little cup measured out, pre-measured from the pharmacy. You'll give that to them to drink. It's really yucky. It tastes real salty. I tasted it one time, not because I have liver disease, just because I wanted to taste it. Why they don't like it. All right. Anything else? What was I talking about? I was talking about the drugs to treat cirrhosis. Okay. All right, so some of these drugs, if they're filtered through the liver, they should not be given to the patient. So, yeah, doctors should know, right? They should know about that, but it's hard for them to know every single drug and know what if there's a couple doctors seeing the patient, so they don't always know what the other doctors have ordered. So as nurses, we have to be aware of all these drugs that the patient's on. All right, let's go back to page 775. And it's talking about the nursing care of the patient with cirrhosis. So their focused assessment, signs and symptoms of complications like bleeding, ascites, encephalopathy, and renal failure. It all fits in there. And then if you'll see the patient problems, goals, and outcome criteria, they've got inadequate nutrition, related to anorexia, metabolic imbalances, decreased activity because they're so tired, skin problems, maybe related to edema, immobility, pruritus, or hypoproteinemia, inadequate oxygenation related to that ascites, big abdomen. They are potential for injury of hemorrhage, confusion related to the blood ammonia, hypovolemia related to hypoproteinemia. It's not keeping the volume in their circulation. It might move into their abdomen, and that's not doing them any good at all. Potential for infection, fear related to dyspnea and life-threatening illness. I remember this one patient I had. He came to the United States. He was a Russian guy. Came to the United States with his wife, brand new, married, and they were walking down the street hand in hand, and she was pregnant, their first child, and she got shot, and she died. And then he started drinking, and he ended up with end-stage liver disease. And we saw him at least 4 times in the ICU because of this. Every time he'd come in, he'd be vomiting blood, and he'd have all these problems, right? And then the day that he passed away, the look in his eyes, he just, his bed was tilted down, because when they're hypotensive, you put their head lower than their feet, right? And he was in that position, Trendelenburg position, and he just looked at us. There were several nurses taking care of him. We'd come pretty attached to him, and he just looked at us. He just knew that this was it for him. But he was probably relieved because, man, in and out of the hospital, it's a pretty bad life. Okay, so let's look at the slide in the stage liver disease. From injury or chronic illness, chronic disease, injury from acute hepatitis, drug toxicity, or obstruction of the hepatic vein. Now, I want to add something here, this drug toxicity. So, Tylenol overdoses, patients who take too much Tylenol, it can damage their liver. And then their liver doesn't function properly from that. And there's other drugs that can ruin the liver as well. Also, obstruction of the hepatic vein could be a tumor, maybe from something else can lead to liver problems. Liver failure associated with injury and fulminant liver failure. Okay, let's go to the next slide, see what that takes us to. If I can get there. Okay, let me talk then until I get there. So we were talking about end-stage liver disease. So all of these things can lead to cancer of the liver. Why can't I change the slide? There we go. Did it. So cancer of the liver, page 777. So cancer of the liver rarely begins in the liver, but it's frequently a site of metastasis. Well, it says rarely begins in the liver, but what if you've had liver cirrhosis or hepatitis? It can be a main source of the liver, but it's frequently a site of metastasis. Cirrhosis is a predisposing factor. Signs and symptoms of cancer of the liver: liver enlargement, weight loss. Weight loss is always a sign of cancer. Anorexia, nausea, vomiting, dull pain in right upper quadrant of the abdomen. The test that you would do would be a CT scan, an MRI, a liver scan, and a biopsy to see if it's cancer primary site or a metastasis. And then measurement of alpha-fetoprotein levels. So that alpha-fetoprotein is a sign of cancer. If the cancer is confined to one area, a lobectomy of the lobe of the liver may be done. Otherwise, chemotherapy is the primary treatment. So that's on page 777. And then we talk about liver transplant. Pretty amazing. Only cure for end-stage liver disease. Transplantation for cancer is confined to the liver for patients with congenital disorders. Ranked by acuity, which means the worst patient is put at the top of the list, the person that needs the liver the most. And they're put into a computer network, ENOS, which is the National Transplant. It's United States wide. So everybody is put into this rank. Now, granted, each state has their own also, but you can get one from another state. So, and this here is showing you a picture of the donor and the recipient liver transplant. So that's the live liver transplant as well. Lifelong drug therapy is needed to prevent rejection. The recipient must always be monitored for signs of rejection. And there's certain lab works that they check for that. All right, we're out of the liver now. So we're going to talk on page 778 about cholecystitis and cholelithiasis. Well, what's the difference? Well, itis and iasis, because they're both chole. So chole's gallbladder. Lithiasis means stones. You can have nephrolithiasis, that's stones in the kidney. So lithiasis means stones. Itis means inflammation. So put them together, what do you got? Cholecystitis, inflammation of the gallbladder. Cholelithiasis, presence of gallstones in the gallbladder. Signs and symptoms can be mild. Some are very painful. It depends on, and if you see in the picture here, you can have stones in the gallbladder, and that can cause you a lot of pain. You can get one stuck in the duct. That can cause a lot of pain and backup of bile into the gallbladder. Very painful. And you can get jaundice when the bile backs up. And fever because of the inflammation. The most serious complication are pancreatitis, because remember, see that pancreatic duct there that's in the picture? See, there's another one here on page 779 that gives a great picture showing you that the duodenum, so the gallbladder and the pancreas both dump into the same area. So you can get a backup, as in that Ruth Bader Ginsburg story where she had to have a stent because she had a blockage of her bile duct that was giving her pancreatitis. So it can happen. And sometimes even when doctors go in with the ERCP, or endoscopic retrograde cholangiopancreatography, we're going to talk about ERCP as a treatment to get stones out. The doctor can go in from the duodenum, from the stomach, and just go right into the duct and get some stones, just as right in that little area there. They can't go up into the gallbladder, however, so they can pull stones out if they're stuck in the duct, the common bile duct. Diagnosis is made on ultrasound and physical exam, so tenderness in that right upper quadrant. If you go to page 779, where it talks about medical diagnosis, it talks about a Hyata scan. So yes, they can do an ultrasound, and that's just getting a bounce back picture of the outline of the gallbladder and maybe the stones that are in it. But a Hyata scan is specific for the gallbladder. They give a dye, so you have to be sure and check allergies. So it's a scan, and it checks the how is the gallbladder functioning? Is it not functioning well because there's a bunch of stones in there? So it's important. It gives an ejection fraction of the gallbladder. So that's an important test also in diagnosing cholecystitis. And also remember that clay-colored stool can also be a sign. It means that bile is not getting expelled from the body. All right, so we talked about the complication can be pancreatitis because of the closeness of the pancreatic duct to the common bile duct, inflammation of the biliary ducts, and sometimes rupture of the gallbladder. Hopefully they can get help before that happens. Diagnosis usually based on ultrasound, physical exam, and then I also mentioned the Hyata scan. Treatment ranges from analgesics, anticholinergics, and antibiotics for pain, muscle spasms, infections, IV fluids, and G-tube. Another test they didn't mention here is the ERCP. I do believe it's mentioned in your book. Under medical treatment, it says, among the options available for treatment, cholelithiasis or choledocho. So choledocholithiasis means that the stones are in the duct. Drug therapy, shockwave lithotripsy, so they try to break up the stones small enough to be passed. The endoscopic sphincterotomy, that's where the doctor goes in with a basket. See, you can have a picture here, 779. It shows the basket trying to grab a stone in figure 40.5. That's interesting. Doctors do that and help the patient. A sphincterotomy is where they open up the opening, the sphincter of Oddi, where the stones or the bile empties into the duodenum. They open up that sphincter so that they can empty into the small intestine and hopefully be just pooped away. All right. So they can have a cholecystectomy, they can have their gallbladder removed. And that can be through the belly button, hopefully. Sometimes it has to be an open cholecystectomy where they actually open the abdomen, but that takes a lot longer to heal. Okay. All right. It mentions on page 779 at the bottom under that picture that a T-tube sometimes is placed in the common bile duct. That's just for extra drainage. I don't want any words to go unknown by you. Oh, here's a great picture. The T-tube, figure 40.6. You can see the T-tube put into the common bile duct for drainage. It's pretty cool. And it mentions what a T-tube drainage would look like, bloody, but it should become greenish brown. And that's usually measured as output, right? If you have somebody that has a drain in. Some patients who have chronic pancreatitis might have a tube in their pancreas also draining. They might get ducts, not ducts, I don't mean that, cysts on their pancreas, and those cysts need to be drained. So sometimes you'll see drains in the abdomen. Be sure you find out if your patient does have a drain, where is it going? What is it draining? What should it look like? And be sure that you measure it for output. Okay. And you can just read through here some of the problems that the patient encompasses with gallbladder cancer. And with either a cholecystectomy or a any sort of gallbladder surgery. There is something on page 781 I want to call your attention to, the patient teaching box of cholecystitis. So that's stones in the gallbladder, right? So a lot of people aren't troubled by them. Now, a patient that has stones in their gallbladder, maybe every once in a while they have a flare-up of the cholecystitis, a gallbladder attack, it might be called. But they need to be on a low-fat diet. Why? Because that bile is what helps break down the fat. So if it has to work less hard or release less bile, it's not going to have to work as hard. So low-fat diet with supplemental fat-soluble vitamins should be ordered by the physician. So that's important to know. Okay, so cancer of the gallbladder, pretty rare, thought to be related to chronic cholecystitis or cholelithiasis. Let's move on. Not much there, just good nursing care support. They might be on chemo, radiation, not good prognosis. Pancreatitis. Very, very sick patients. They do not feel well at all. It's an inflammation of the pancreas. Abdominal pain is typically severe with sudden onset, severe vomiting, flushing, cyanosis, dyspnea, and fever. It can be abscesses, pseudocysts, hypocalcemia, pulmonary, cardiac, and renal complications can occur. So I had a patient who kept coming in with this pseudocyst. It kept recurring. They'd put a drain in, get rid of it, then it would return. He'd have to keep coming back. So patients who have recurrent diseases or recurrent episodes, problems, it's depressing. They get really very sad, and it's really tough on them. So we have to really be supportive of these patients who have chronic diseases. Key diagnostics are elevated serum and urine amylase. So that's important in relation to the pancreas, amylase. Also serum lipase levels. Treatment usually starts by making the patient NPO because they don't feel like eating anyway. So we don't want any stimulation of the pancreas for digestive enzymes. So they are put on NPO. So there's no stimulus for pancreatic fluid secretion. Nursing care focuses on pain, fluid volume deficit, because they might be vomiting Potential for infection. What if it's a abscess? So potential for infection. Inadequate oxygenation. They don't want to breathe real well because it hurts. Inadequate nutrition, anxiety, and lack of knowledge. It's very scary. So let me just say something that's not mentioned here, but on page 783 under pancreatitis, chronic pancreatitis, which is often associated with alcohol abuse. So again, that same area, it's going to all affect each other. Liver's going to affect the pancreas. So pancreatitis a lot of times, not always, so don't accuse somebody though in pancreatitis that they're alcoholics. But it is often associated with alcohol abuse, and it may follow the acute condition but often develops independently. In addition, chronic pancreatitis is sometimes associated with cancer of the duodenum or pancreas. So remember that digestive enzymes might be activated. Signs and symptoms: abdomen may be tender and distended. The bowel sounds may be absent, suggesting an ileus. Enzymes released. Now I'm under signs and symptoms on page 783, if you're with me, under pancreatitis. So I'm talking here, symptoms of chronic pancreatitis are similar to those of the acute disease, but usually appear as periodic attacks that become more and more frequent. In addition, patients with chronic pancreatitis may develop diabetes. Remember, the pancreas is exocrine and endocrine function, and it has digestive enzymes, and it makes your insulin and somatostatin. So patients with chronic pancreatitis may develop diabetes mellitus and malabsorption with steatorrhea. Complications of pancreatitis on page 784. Pseudocyst abscess. What is a pseudocyst? Well, it looks like a cyst, walks like a cyst, but it's not a true cyst. Pseudo meaning resembles a cyst. Abscess, pulmonary, cardiac, and renal complications. So here it says a pseudocyst is a fluid-filled pouch attached to the pancreas. It contains products of tissue destruction and pancreatic enzymes. The fluid can leak into the digestive tract or the abdominal cavity, and that can include abdominal pain symptoms, nausea, vomiting, anorexia. Okay. Patients usually run a high fever with pancreatitis also. Hypocalcemia, or low serum calcium, is caused by action of fatty acids on calcium and increased loss of calcium in the urine. All right. Remember here on page 784 under medical diagnosis, it mentions the most important diagnostic finding is the serum amylase. Very diagnostic of pancreatitis if it's elevated. Also the serum lipase. Medical treatment, NG tube connected to suction IV fluids to restore and maintain blood volume. Urine output monitored at least 40 mL an hour. They might need a feeding tube or TPN. I'm on page 784 if you're with me here. Drug therapy for pancreatitis includes antispasmodics, anticholinergics, gastric acid inhibitors, pain control. And if you go on down under drug therapy, it says with chronic pancreatitis, acetaminophen, ibuprofen, or tramadol is tried initially for pain control. And if these non-opioids don't work, then they might have to go on to opioids. The patient with chronic pancreatitis is likely to need to take pancreatic enzymes to digest food. So there are pills that have pancreatic enzymes. I'm just going to throw this little bit of information in. You'll know this for another time. Patients with cystic fibrosis have pancreatic problems, digestive enzyme problems, and they are on pancreatic enzymes. So that's another kind of person that might be taking pancreatic enzymes. All right, other drugs, antacids, anticholinergic histamine blockers, surgical intervention. They might need to do the endoscopic sphincterotomy where they take out a stone from the gallbladder because that's causing problems with the pancreas. Might need to have the gallbladder removed. They might, if an abscess, pseudocyst, or severe peritonitis develops, surgical intervention is indicated. And a stent might be put in to keep the opening of the gallbladder or the pancreas open. It's the same way they do it with the heart. It's a stent that keeps that open, in this case ducts, but in the heart, of course, it's an artery, but nonetheless, they use the stent for either thing, just to keep something open. Nursing care for a patient with pancreatitis. So they're going to be in a lot of pain, fluid volume deficit related to vomiting, and if they have an NG tube, they might have electrolyte imbalances, potential for infection. And I'm on page 785 here. Potential for inadequate oxygenation because of fluid accumulation, and they feel awful, so they don't cough and deep breathe. They take little short breaths, so we're going to have to encourage them to cough and deep breathe because they're not going to be getting up. They feel so bad, so they're on bed rest, so we have to have them turn, not stay in the same position all the time. Inadequate nutrition. Initially, the patient will be NPO because fluid and food stimulate pancreatic fluid secretions, and they want that pancreas to rest and not become inflamed anymore. All right, and then we talked about the pancreatic enzymes they might be given. And if you turn to page 786, there's a care plan there, nursing care plan, patient with pancreatitis. That's interesting. Now notice this lady has pain in the left upper quadrant. Right upper quadrant, we can think gallbladder. Left upper quadrant, you can think pancreas. So that's interesting. Read through that. Okay, I'm going to go to the next slide. Cancer of the pancreas. So although signs and symptoms may vary with the stage and location. So I know when we talked about the pancreas before, I mentioned cancer can occur in the head or the tail. It depends. It depends on the location and the stage that the patient's that it's caught in. It doesn't have a lot of symptoms. I knew one patient who had pancreatic cancer and she just had back pain. So she kept going to a chiropractor to adjust her back. And by the time that she got jaundice, it was already stage 4. So it can grow pretty fast. Weight loss and glucose intolerance would be another symptom of cancer of the pancreas. Medical diagnosis, MRI, CT scan, the ERCP, endoscopic retrograde cholangiopancreatography, and that is where the doctor does an EGD, and he goes into the duodenum and goes down to that opening to the gallbladder, and sometimes he can get a stone there. MRCP, that's more focused, that's like an MRI of the pancreas. Surgery may be option if the tumor is contained to the head of the pancreas. Other options like the Whipple procedure can be used. So the Whipple procedure is like a bypass of the pancreas. Nursing care focuses on pain, fear, and grieving, inadequate nutrition, potential for disrupted skin integrity, altered body image. And remember, amylase, very symptomatic of pancreas problems. Oh, if you turn to page 788, it shows you some great pictures, figure 40.7, the sphincteroplasty, the side-to-side pancreatic where they put a drain in, caudal pancreatic jejunostomy. So that's pretty interesting. Shows you some things that they can do to help the patient with pancreatic surgery. Now, there's been several famous people who've had pancreatic cancer. Steve Jobs had pancreatic cancer. Now, he had the kind that could have been helped, but he had other ideas. He wanted to go to Mexico and get some sort of treatment down there. He thought probably, I don't want to say this isn't nice, but he probably thought he was smarter than everybody. So he'd get other treatment rather than the one suggested by his doctor. Didn't work. He did get a liver transplant trying to help him, but he ended up losing his battle with pancreatic cancer. There was also, who was the guy? Little House on the Prairie. What was his name? Oh, there's been several. Also, Patrick Swayze also died of pancreatic cancer. I know when famous people have cancer of the pancreas, it's all in the news, but it happens to normal, everyday people too. All right, surgical complications. The Whipple procedure has high risk of hemorrhage, fluid and electrolyte imbalance, respiratory, renal, circulatory, hepatic failure, wound infection, and dehiscence. Think about this for a second. So sometimes the treatment's worse than the disease. So is it worth it? Some patients, they don't want to go through all this. They'd rather just die with their family members. And some patients do want everything to possibly be done, and they'll undergo all kinds of treatments trying to stay alive. So it depends, depends on the person. And are they on hospice? There's always hospice treatment that can help the patient be more comfortable. We always want to make sure our patients are comfortable as they can be, no matter what choice they've made, no matter how they got there, from drinking or whatever. Maybe you don't be judging them for drinking and getting into this situation. It can happen to anybody. So we as nurses, we have to be very sensitive to that. All right, if there's surgery, remember there's always complications with that. Monitor their vital signs, INO, their blood glucose, because pancreas, insulin, right? It's digestive and insulin. So we got to manage their blood glucose levels. All right, I bet you can't believe I'm done, but I am. I think maybe I have one more. A question. All right, hepatitis what? Oh boy, but that took us back an hour and a half. Hepatitis what is transmitted from one person to another by way of water, food, or medical equipment that has been contaminated with infected fecal matter. Which hepatitis? I'll give you a minute. So the answer is A. Hepatitis A has been called infectious hepatitis and epidemic hepatitis. It's caused by the hepatitis A virus, which is transmitted from one person to another by way of water, food, or medical equipment that's been contaminated with infected fecal matter. Hepatitis A is the most common type of viral hepatitis. All right, hope you enjoyed this lecture. Study hard for the lot of material we've got on chapters 37, 38, 39, and 40. Just keep listening to the tapes. All right, you can also do your NCLEX questions, key points at the end of the chapters. And if you come up with any questions, you can always ask. All right, thank you.